campus, and this was like Dr. Rice's brainchild. This is the environment that we promote. And so I expect you, if you're at the hospital and some of your peers are not being civil, y'all ain't gonna lie. She's never asked us. Y'all know what I had to do with my first civility day?
What'd you have to do?
Look up the definition. I mean, I'm serious. I know what it. Oh, you're not being civil, but I'm like, damn, what we talking about on civility day though? Are we gonna yell at folks? I mean, I really did. I never told her that. She probably would. No, she did all right. They yell at us. So this is gonna be quick, but guys, the first part of this, if you can absolutely, like, if you got to, you got to. I don't want you to take notes. I want you to listen to me. There. Oh. Girl, you don't know you're gonna get snatched up. I'm just saying. Look, she was like, I got put me in, coach. I got it. Woo!
About to.
I'm so sorry. I said 15. Somebody told me 10:15. I'm sorry.
Oh,
really?
Girl, 2 minutes, really? Give me my 2 minutes back right now.
How do you not know when class starts?
That's it, 30 minutes.
Closing her out. We love you.
Love you, Megan. Hey, she's gonna teach y'all a lecture.
Yes.
Yeah, really. She's gonna do hematology. Just wait on me this semester. Yes. Guys, here's the thing about cardiac. Who's in here says, I hate cardiac, it sucks. All right, great. Where are you gonna work? You got a lot. So, cardiac is everywhere. The last time I worked at Cumberland Hall, they called it code blue. Now, the person had a seizure. They weren't breathing when we got down there, so justifiably so. Can people at psych hospitals go into cardiac arrest? Yes, they can. You still have to know how to do these things. If you don't remember anything else, there are 4 lethal rhythms. It's like sight words. Anybody got kids and them damn sight words? Pronouncing the and the. And my son come up with his own sound that came from, I'm like, I don't even know what to say to you right now because I don't know how we pronounce it either. And Common Core, we didn't even talk about it. Anyway, besides those 4, if you will be flexible with me and keep an open mind, by the time we get done with this PowerPoint, you will know what every rhythm is, or you'll be able to figure it out and name it. The 4, you've got to know backwards, forward, what you need to do immediately, what meds you need to give. I'm not asking dosages. That is what you're responsible for, and tomorrow, that's what you're going to be doing. Guess which rhythms you're going to get in the mega code? Those 4.
All those.
I'm telling you right now, whether it's VTAC without a pulse or VFib, you're going to get down to amiodarone. Just go ahead and put it in your mind. We're going to get there. And if you mess up and you just keep going, I'm going to let you keep going until you get to amiodarone. So y'all need to, can't push it first. And say, I'm done. No. You was totally going to do that. Yep. How do they name cardiac rhythms? Where did we come up with this? They didn't just say, oh, we call this atrial fibrillation. Some guy thought, say it louder.
Where it's happening.
Where you were right there. Rhythms are, no, you're exactly right. Why do you think I asked you to go back over? Guys, there are things you should be knowing by now. That you should already know. Anatomy and physiology, the blood flow through the heart, the electrical conduction system, because this semester we're going to build on that. I expect you to know it. I expect you to know what the little bitty boxes are on the EKG paper. Without that knowledge, this is worthless. If you don't know what normal is, how can I tell you what abnormal is? every rhythm is named from the pacemaker it originates from. And then you add on tachy or brady. That fair? So these terms are not in my slides, but you need to know what these are. And I know you've all heard these. What is depolarization actually? It's the contraction. So the QRS complex is the ventricles, the P wave is atrial depolarization. What is repolarization? When we're relaxing and trying to get back to where we were. What if I come up and punch you in the chest while this is trying to work? Y'all remember that football player?
Yeah.
Where'd he get hit right before that?
In the chest.
Right in the chest. God was looking for him that day because there was an EMS crew right there. They got the defibrillator on him, I don't even know, like less than a minute. And if you look at it, you can see what they're doing down between his legs, and you see them shock him. It puts them immediately into his V-tach, usually it's V-fib. This is why all the young guys that's playing baseball or young ladies and they hit the line drive, hits them in the chest, they fall over dead. They might have long QT syndrome, which is a medical diagnosis that they don't know anything about. But those are just basic terms. All right. Here is the crux of all of these rhythms. What normally runs a show? What does that stand for? Normal sinus rhythm. Where's it coming from? The sinoatrial node. Sinus tachycardia. Where's it coming from? The SA node, but what? It's just too fast. What'd you say? Why do we call it tachycardia though? If I said, what's normal heart rate for 1600? Yeah. What does that even mean? That is how fast this normally fires. This is where we're supposed to live. But what if this one ain't working? What do we go to? The AV node. So AV node, bundle of his. Now, if this is running the show, the heart rate is anywhere between 40 and 60, right? All right, I'm gonna blow your mind. Ready? This is called the junction, right? So if I have a strip and I know it's a junctional rhythm and it's 50, is that a regular junctional rhythm? What if the rate's 80 and it's junctional? Junctional tachy. Now, I know that we talk about, and it is, but so where does it go from here? Right and left, bundle branches, and then where? Purkinje fibers. This is just collectively the ventricles. If you down here, or heaven forbid, if you out here, it's 20 to 40. But if this is pacing the heart, right, and they have a pulse, and this is 150, and it looks like ventricular what? Tachycardia. That's where that rhythm is coming from. That's how you... Did I lose you? Oh, you just look like me. Will you talk about That's why I asked you to look back over this. You want to know the honest truth? I didn't learn this till about 3 years ago. Nobody had ever mentioned that to me, and I'm like, oh my God. A blank screen. For the four that are not, yes ma'am.
What is junctional? Just don't.
Don't. I was just trying to tell you that because that's where it's coming from. Guys, there are 9 rhythms. That worksheet that I gave you, that the NCLEX test on, that's all 9 of them. Now guys, I can't say that beyond a shadow of a doubt, but I go through and look at the people that write the NCLEX, that's the ones they test on. Guys, there's so much cardiac that we can teach. I'm not talking about blocks. Why? Does anybody not know how to treat anything that's bradycardic? Pace them. Too slow, pick up the pace. Second degree type 2 and third degree heart rate is always bradycardic. You're not going to pick out what med to give them. You are responsible for what? That electrical therapy. What does it matter if you know what kind of block that is? Hey, that's too slow. I need to do something. And what am I going to do? I'm going to pace the patient. That's what, guys, and if y'all want to talk about these rhythms, I will talk about you all day after class. I try to teach you the things that are the most applicable everywhere. If you think, I'm going to work on that Saturday, it ain't never going to happen. Keep lying to yourself. The only place that this really won't happen is in the NICU. They got fast heart rates or slow heart rates, and you give them some epi, or you, I can't remember how they bagel them down. Besides the 4 sight rhythms, 5 things. Guys, when you do your patient assessment, if you all over the board, you're going to do what? You're going to miss something. That's why we teach you this, and that's why we practice like we play, right? Because if you learn this way, the second you step out, that's what you have to rely on until you can get some experience in, and then you can kind of skip over. 5 things every time for every rhythm strip. I want to know the rate, which is what? Fast or slow? What's the rhythm? Is it regular? Is it irregular? And we're going to quantify these a little bit. P waves. I need to look at the PR interval, and I need to look at the QRS. Nothing else. Don't add anything. Because then you start getting into these weird unicorn rhythms. Guess who's going to diagnose that? The cardiologist. You wouldn't see the ER doctor going. You call cardiology? They know when to shop them like we do. But when all that weird stuff comes in, they're going to call the people that do this all the time. Now, I'm not going over this. This is something that should have been covered. If it was not, there's a site, I think it's ACLS Quick Review or something. The information is valid, and I think they show you how to do this. This is the easiest one, the 6 second. I'm telling you right now, any test I give you, any worksheet I give you, it is 6 seconds. You're going to say, it is. We 10 in like. 6 seconds. How many beats? Multiply it by 10. 1, 2, 3, 4, 5, 6, 7, 8, 9. 90. Now, is that the most 100% accurate? Not really, but it gives you a good idea whether it's 70, 20, 150. After you look at these, you can look at it and say, oh, let's lower 100. We need to do something. Less than 60 is Brady. Greater than 100 is tacky. Because which pacemaker site are we talking about? The SA node, the normal pacemaker for the heart. Rhythm. Is it regular? Am I just talking about the QRS complex? I am not. I want to know R to R. That's ventricle to ventricle, right? Ventricular contraction. And I want to know P to P. Do we need any calipers? Do y'all even know what that is? The little pointy things that they gave me in paramedic school, and I stabbed myself with it 5 times, and then I put that shit in home. It looks like a compass. You know what you need to measure this rate with?
Piece of paper.
Right here. And so, I'm going to get my little pen. Guys, you have to print it out. There's nothing wrong. Now, if they're dead, don't go. I'm going to print this out. So, you'll make a mark on each QRS, and then you just move it, and move it, and move it, and then you know it's regular. It won't take you but 2 or 3 QRS complexes, and you'll know it's irregular. You do the same thing for the P wave. This don't cost nothing except for the admin person's wage. Rate, rhythm. Now, the P wave doesn't have any measurements. The PR interval does, right? It's what? Point what to what? Point 12 to point 20. This is the P wave. P wave, QRS. And what is this? The T wave. We are not talking about the ST segment until next Monday when we talk about MIs. Because here's the thing. Oh, this is a cool strip though, it's got by Jimmy. What is this used for? It's EKG. Is it this? Hell no. You know what this is for in our world only? To figure out what is this patient having a STEMI? For us, guys, I ain't talking about, not that I don't care about anybody else, I'm talking about us. I want you, if they were to print this EKG out and you walk by and you're like, oh hell, then you go get somebody, i.e. the physician, right now. There ain't no, right now. Working at Sango over 2 years, there were probably 15 STEMIs that were diagnosed by the medics or the nurses. You might have saved that person's life. That's what this is good for. Not figuring out rhythm strips. Because you can do this quick, fast, and in a hurry. That takes a minute. You gotta put it on, you gotta get in order. So there's things I want to know about the P wave. Is it there? One for every QRS. It's supposed to be. Do they look right? Are all of them upright? Does this one go this way? This one go this way? This one doesn't have one? That's a whole different can of worms. The P waves, for all purposes for us, represents the atrium. That's it. I don't want you to think about anything else. P wave and PR interval represent the atrium. So if something is wrong with the P wave, where's the problem? In the atrium. Now, does anybody know what the PR interval actually is? So it's 0.12 to 0.20, but what is it? What's happening in the conduction?
ventricles are filling.
Huh?
The ventricles are filling.
They are, but what is the conduction system doing?
So you like visualizations and relaxing so that way your ventricle actually visualization.
So y'all are exactly right. The ventricles are filling, we're taking a break. It is a brief pause. That's why it's at the isoelectric line, which y'all know what the isoelectric line is that's where everything originates from. But that's why it's there. So the PR interval is right as you get to the AV node. Atrioventricular node. It's moving down. So if I've got an issue here and the impulse is blocked, what would I call it? AV type 1, AV type 2. Type 2 first degree segment. Those are not in the ventricles until you kind of get down to the third degree. I'm just trying to show you as it moves down and moves pacemaker sites what this is going to mean. So you do need to look at the PR interval. Is it there and is it within its normal ranges? Because it works in the conjunction with the P wave. I cannot say this is a normal sinus rhythm if something is wrong here, right? Because it doesn't fit the parameters for a normal sinus rhythm. Here again, if something is wrong with the PR interval, there's a delay in conduction, but where's the problem? is somewhere in the atrium. It's got to be above the ventricles. If it were below, if it were down in the ventricles, this would not be an atrial rate, an atrial rhythm. It would be a ventricular rhythm. Does everybody with me so far? Sometimes it will take you to getting to here to figure out what this rhythm is. So this is a QRS complex. What does it represent? Ventricular contraction. There's the measurements. The QRS complex represents the ventricles as a whole, just like the P wave and the PR interval represent the atrium as a whole. Guys, why am I reinforcing this and reinforcing this? This is the crux of figuring out everything. Because if there's a problem with the P wave, it's an atrial rhythm, right? And we only got a few we can guess from. You narrowed it down a whole lot. How do you know there's a problem? If it's too wide. Can it be too narrow? I mean, it can. We ain't getting into that. I mean, it can. But that's, never mind. I ain't talking about that. I want to know if it's too wide. So, when we get on these strips in a minute, I'm going to say QRS wide or narrow. All I want you to tell me is which one it is. Now, you ain't going to get up here and count, but you see what that is. You can tell if it's wide or narrow, right? Y'all don't know what that is? Hallmark card? What is a hallmark sign? This is the elephant on the chest. It ain't a hippo, it ain't a buffalo, it ain't a rhinoceros. It's always a damn elephant. And that sits on their chest. And when they say that, and then they got their hand like this, which is Ludwig's sign, all this is evidence-based, you need to get the EKG right now and bring the physician in there with you. This is the worst headache of my life. Stroke. Oh my God, I've got this ripping, tearing pain between my shoulder blade or in my stomach. It feels like somebody's stabbing me and they're dead. What happened? I had a ruptured AAA. If they ever describe anywhere that's in the aorta as, oh my God, it's ripping, tearing, right now. Hallmark signs. So, the hallmark sign for these two atrial, well, there is a ventricular one, but for the two atrial flutter has a sawtooth pattern. It looks like a saw. Atrial fibrillation is the isoelectric line is quivering, right? So, atrial fibrillation, where's the problem? In the atrium. Ventricular fibrillation, where's the problem? In the ventricles, and they don't have a pulse. That's it. Does atrial fibrillation have a pulse? I certainly hope so. Let's try it. Guys, I've given you the rate. If this were a 6-second strip, what is it? 70. All right. Maybe. Come on. Got it. Beat you. What's a rhythm? It's irregular. Sometimes isn't this obvious? It is not. Sometimes you got to get that paper out and really look at it. All right. So, the rate 70, the rhythm's irregular. I want you to keep that in your mind. What about the P waves? Sometimes that fibrillation actually is P wave, but there's a ton of them. Where's the problem? In the atrium. Now we ain't got all the way through, but we got that in our mind, right? It's irregular, and I've got these, what kind of waves? Fibrillatory waves. Hallmark sign, right? But you can't really distinguish them. What about the PR interval? I ain't got no P waves. I can't figure it out. Here is what is the deciding factor. QRS wide or narrow? Where's the problem? What kind of waves? Fibrillation, atrial fibrillation. Now, okay, what's the rate? It's like 300. Your monitor's not going to pick it up, or it's going to give you something stupid. It's rapid. Hallmark sign. Absolute chaos, right? Rhythm. Oh no, it's irregular. It ain't regular. I know that. Okay? Grossly irregular, chaotic, fibrillating. P wave. Nope. Unidentified. PR interval. Ain't got no P waves. Can't see it. Now. That kind of looks like a QRS complex. Kind of, but not really. But in our world, it's going to be. If that is a QRS complex, wide or narrow? Ventricular fibrillation. They don't have a pulse. What are you going to do immediately? Defib. VFib gets defib. Pulseless VTAC gets defib. That needs to be immediate. Ain't nobody got to tell you to do that. Patient runs in. They ain't going to run in if they have VFib. It's a miracle. Guys, when y'all are, I don't need to tell you in that code. If you see VFib, you don't have to ask me. Guys, y'all gonna be a nurse. Put the pads on and go ahead and get ready. All right. I guess I need a new battery. What's the rate?
120.
It's 120. Fast or slow? Fast. Rhythm. Very regular. P waves. They're there. One for every QRS complex. They all look the same. Okay. PR interval. It's there, but it's almost too short. QRS wide or narrow? Where's the problem? What is the only problem with this rhythm? Where's it coming from? Sinus? Tachycardia. What's the rate? It's 210. Do you have a question? I'm sorry.
Yeah, where'd you get the sinus from? Like when you said
So, everything is fine, right? The P wave is fine. The PR interval is fine. The QRS, everything is within its normal measurements. If I just put, if I cut it off right there, that's how many beats per minute? 70, right? Let's say that's a 6-second strip. 70 beats per minute. Let's go through it. P wave, PR interval, rate, rhythm. We go, everything is normal. What's the only problem? Why can't I call it a normal sinus rhythm? It doesn't fit that parameter. What if the rate was 20 and everything's fine? Sinus Brady, right? If you looked at that, there's not a ventricular Brady because the rate is like 20 to 40. But there can be something where it'll be going in a straight line and it'll have these great big wide QRS complexes and they still have a pulse. It's called the idioventricular rhythm. Because I mean, you can't get a whole lot slower than 20 and that's just dead. For it to be sinus Brady, everything has to fit every parameter for a normal sinus rhythm, but I can't call it that. Now, is it regular? Is it chaotic? No, it's not. It is regular as the day is long. It is is a very regular. What is the most important thing when I see that? This is the sight word. When I see this, what I want to know? Patient have a pulse or not? No pulse. Immediately what? And start CPR. You don't have to ask anybody. I ain't got to ask God. I'm just going to put them pads on and somebody starts CPR. If you're the nurse in the room, hit that code button. If it's just you, you got to do what first? You can't just defibrillate them. You got to start CPR. When the cavalry comes a running and they see this that's going on, and at Tennova, if you're working in the ER, and this is all evidence-based, we do nurse run codes. What does it let the doctor do? Talk to the family. And find out the patient's a DNR. They just got there. It was not our fault. Put in a central line. Do other doctorly things, and he doesn't have to sit there and run the code. Usually it's an experienced charge nurse or the assistant manager. Guys, it works well. Guess how they get the knowledge to do that? It's off ACLS guidelines. That's it. They don't throw anything else extra, and if they take them to court, you would say, I followed all ACLS guidelines and protocols. There's nothing they can do. You did everything that a nurse in your level of training would have done, and it's by national guidelines. They don't have a leg to stand on that you did something above and beyond. Now, might the doctor order a different med? Yes. Rhythm is regular. P waves. If they are present, they're buried. PR interval is the same. Guys, that is QRS complex is wide or narrow? Where's it coming from? What's the normal rate? 20 to 40 for the ventricles. Ventricular tachycardia. Why is it not sinus tach? I can't even see the atrium. And the QRS is wide. That means it's coming from the ventricles. If it's being paced from the ventricles, that pacemaker site has to fire. It has to go all the way out through the Purkinje fibers and come all the way back up and down back through. That's why it takes so long. Because the SA node starts right here, right? And we just bam. I got to jump all the way back to the top of the building, walk down 5,000 flight of stairs, and I'm tired by the time I get out, so I'm walking one step a minute. All right. Does anybody know what that is? Why do I call it a PVC? What other kind of premature are they? PACs? Okay. What if I tell you you can use the 5 things to figure it out? We're going to skip rate rhythm. P-wave. It doesn't have one. QRS wide or narrow. So this rhythm is normal, right? But I can't call it normal because something's kind of off key. Sinus rhythm with a beat that's coming too soon. What do we call that? Premature. Sinus rhythm with premature, what kind of contraction? Do you see what I just told you? This is a ventricular beat. It's in a sinus rhythm. There ain't nothing wrong with that. This is a premature beat, and it's coming from the ventricles. So what do you think a PAC looks like? It's got a P wave, and the QRS is what? The QRS is narrow. The only problem is it's coming too early. Here we go again. Where's the problem? Right here, right? That's where you tell it there's something that's coming too soon. It's not supposed to be there. So we're just looking at this beat. Does it have a P wave? It does. The PR interval is normal, I'll tell you that. QRS wide or narrow? It's narrow. What kind of beat is that? An atrial beat. Is coming too early. Premature atrial contraction. Why is it not a PVC? That's narrow. And it's got the atrial activity. Do you see what I'm telling you? normal sinus rhythm? No, it has something in it that's wrong. Guys, you won't, and I say this hesitantly. There are some things about cardiac V strips. Those parameters are absolute. If it ain't 60 to 100, then it's not this rhythm. It's not a normal sinus rhythm. I can't call it that. If it's 120 and everything else is fine, I can't call it a normal sinus rhythm. Do you get what I'm telling you? Every one of these has to meet certain parameters. If it's got the sawtooth pattern, it's atrial flutter. I'm going to show all the rhythms in just a second, and then this will hopefully make sense. Guys, I don't want you to memorize anything but those 4 things. I want you. This is just Ms. Horton. What is my job for y'all? No, I'm not teaching you anything. I am going to teach you about the NCLEX a little bit by the test I give you. I don't teach to that test. What am I trying to get you to do? Think critically. That's not something you come into this field in fundamentals. We all think, oh my God. They start it there. If you can think through a problem about 90% of the time, even as a new grad, that will get you through the problem. You might not do it perfect. You know, everybody's always like, I'm working for, no. I'm working for progression and performance. Now, I expect you to know these things, but memorizing is not going to do you one damn bit of good.
For the PC, you say it's normal sinus rhythm with PC.
It's not normal. It's a sinus rhythm.
Sinus rhythm.
Because if this wasn't here, and that beat was where it should have been, then what kind of rhythm is it? It's a normal sinus rhythm. It meets all the parameters. I can't say it's normal. There's a problem. PACs, not so much. What if I see a whole bunch of PACs? 5 or more in a row? 6. 5 or more in a row is a run of VTAC. PVCs can be indicative of a lot of things, but if you start seeing them frequently, your patient's hypoxic. You need to do something. And what's getting pissed off? The ventricles. What's the ultimate ventricular pissed off? Ventricular fibrillation with no pulse. A lot of times, not every time, the patient will be in VTAC first, and you didn't do anything. Maybe VTAC with a pulse, and you didn't do anything. I don't know what that rhythm is. Oh, now I know what it is. It's asystole. Guys, can I tell you how many patients I've got back that were in asystole? None. 0. I've been doing this since 1998. I don't even want to know how many codes I've worked. The ugly truth. You're not going to get a lot back. Not adults. But the few you do is what keeps us going. And that's why we do this every time, like we trained you to do. Y'all take a quick break. Some water, some y'all got.
Yeah, I didn't even know it was still open.
I usually do it on my computer and then have it to my
Alright guys, our time is short. You can keep standing if you want to, that's fine. Keep standing still. Do you remember how I said I set up my PowerPoints? Well, the latte method. Looks like what assessment you'll do, test treatment. For every cardiac patient, you're going to do some of this. For some cardiac patients, you're only going to do one of these. All this is a generalized, what we would do for an assessment. I mean, for any cardiac patient, what's one thing you know you're going to do? Check their pulse, that's paramount. And an EKG. I don't care what rhythm they're in. Even if they come in having difficulty breathing, what are they going to do? An EKG. How about I passed out and I'm like my age? An EKG. Why do I want to know that if you had a syncopal episode? It might be cardiac related. Pretty much every EKG, every cardiac is going to get an EKG. Why is this important? What questions do you ask if they're having chest pain? Describe it.
Where do you feel it? Where?
How long it's been happening?
Where is it?
Where is it? It's in my right toe. That ain't chest pain. What's one we missed?
Is it local or radiating?
Does it come and go? What'd you say? Does it radiate? What's that mean? Starts here and goes somewhere else. For my young men, what are the typical radiation patterns? Right? Good God. Yes, left arm all the way down in here. There's one more place that sometimes we forget. Their jaw. If they come in and they sweating and short of breath, God, my jaw hurts, I must have it. You better go run and get the EKG. And then they tell you, my daddy died at 45. Can somebody bring me the EKG right now? Right now. If Jesus is in the way, Jesus, I love you, I gotta get the EKG. When we had a huge cohort, and I had to teach 4 hours, 2 days a week. And guys, by the end of it, I just said some of the most stupid shit. And I was trying to say you get serial EKGs, and it came out I need an EK Jesus. One of the girls like, next time I get to know, I'm yelling out, I need an EK Jesus in room 7. I said, I hope that don't mean you're getting an EKG and they need Jesus. No. Quality. What does it what? Feel like. Don't try to prompt them. Because you say, is it sharp? Yeah. Is it dull? Yeah. Am I a unicorn? Yeah. Maybe. How might they describe it? Pressure. Like an elephant's. I'm really nervous now. Usually they don't describe it if it's truly a heart attack as a sharp stabbing pain. Now I'm not saying, does everybody read that book? I am supposed to have dull pressure and the elephant is supposed, no! Just because they don't say all that, you ain't having a heart attack. They might say they feel like there's something is sitting on their chest. They might not get to the elephant. I've even heard it feels like there's a pressure and it's a band around my chest and it's squeezing. Any of those pressures, squeezing, aching, compressed, it's radiating to my left arm. Guys, and don't just say, if it's in your right arm, it ain't a heart attack. I've seen it twice, because I'll be honest, I was totally joking this patient. You asked me for a sandwich. Oh my God, you'll go get the doctor. There's EKG. Having a huge stent. His troponin was 18,000.
Oh, nice.
I don't know. I mean, he's going to take it to heaven with him if we don't stop him. Guys, vital signs. Always, always, always. Chest pain, shortness of breath, syncopal episode. If you're not doing this and you're not doing what you should as a nurse, blood pressure, pulse rate, respiratory rate, pulse ox. So if you're in there and you got them hooked up, you doing what you're supposed to, and you're sitting there and you're like, that blood pressure ain't reading. And then you move on. They're still talking to you, but they're kind of modeled. And guys, we talked about skin color. Pale is what? Blood loss. Cyanosis is what? Hypoxia. And this color is so hard to describe until you see it. And then you're going to come back and say, Ms. Warden, you were so right. It's gray. It's a little bit darker than this young lady's bag right there. If you see that color, it ain't cyanosis, it's not blue, it is gray. Don't even get the EKG, go get 3 physicians, the cardiologist, and God. I have never seen that color without them be actively having a heart attack. I don't know why. I don't know if it's a mix between cyanosis, pale, and God, and I don't know. But that color. Also mottled means their perfusion is bad. Put the SpO2 on them. Cardiac monitor. Why am I monitoring LOC? If your brain ain't getting what, then you start acting strange. What if I told you you walked out and they were fine with LOC and you walked back in and they're so anxious? Is that altered LOC? It is. Guys, this is NCLEX all over it. And when it gets to TBI, when it gets to shock, anxiety, restless is the first, and I'm telling you this from experience and from NCLEX, the first sign of hypoperfusion, i.e. shock, is what? Anxiety and restlessness. And then it goes to everything else. Altered LOC. NCLEX considers, and it is, you walked out, they were fine. You walk back in and they're picking at stuff and they weren't, and oh my God, something's wrong. And then when they say this, oh my God, I feel like I'm going to die. You better what? You better listen to them when they say that, because they're going towards the light, Carol Ann, when they say that. You might not see anything else. And then they break out in a sweat, and I ain't not listening. I'm talking about diaphragm. This is going down right now. Weakness, dizziness, restless, heaven forbid, sinkable episode. Now they fell out the bed. What blood tests and what other diagnostics might we include?
Blood sugar.
I want to know blood sugar. That's very good, because if they don't let that sneak up on you, like they diaphoretic, they had a sinkable. Let's get an EKG. Let's get a blood sugar first. Bring the EKG and the Accu-Check in there at the same time. What is this? What does it represent? That's pretty much it for our world. If your BNP is 12,000, you got heart failure bad. What am I looking at in here? What is this? Which one specifically? Sodium, potassium, and one more, magnesium. These chest pain levels, if they just get a BM, even a CMP, it doesn't have magnesium in it. They will order it. Why you're a drug screen? If you beating along at 200 beats a minute, what do I want to know? Do you take any prescription drugs? Do you take any around the corner drugs? Right? You took a hit of meth. Well, you think your heartbeat would be 200. Chest X-ray. Why? I want to know if there's any trauma. Can that cause chest pain? I want to know if I see fluid on the lungs. What are cardiac markers? Troponin. What is that? That is released when? When your heart is dying. It is very specific to it's cardiac injury and really cardiac death. You might get this much of a bump with sepsis, but it is not myocardial infarction levels. Like it's a tiny little bit. I ain't worried about a tiny little bit. It might actually be in the parameters. It's up at the upper end. Why this? Yes.
Do you think we could open a window?
Guys, it is.
There's one over.
Y'all, please be careful with that. Y'all heard what happened to Miss Sutton, right? Yeah, that's why I haven't opened the windows. Like, usually you would have seen me up here and got two of the girls or guys to help me open the window. It fell down and hit and broke her arm, so that's why I haven't been asking her. He's like, you don't volunteer me for this.
I need somebody else on that side.
Two votes.
Yeah, if y'all are gonna open it, let's at least get 2 people.
They need to come on the other side.
Thank you guys.
Yeah, if it ever goes, don't just step back and let it break. Now, I don't know why we have such problems with figuring this out. I mean, I don't know any other way to teach it, but I've never taught cardiac before. It's always somebody else. What rhythms do we synchronize cardio over? Don't even tell me specifically. What kind? Fast. What kind of rhythms do we pace? Slow. I want to pick up the pace. What rhythms do we defibrillate? Do you know what another name for this is? Unsynchronized cardioversion. This ain't the machine decides where, this is Shayla decides where to shock. And you just pow! When you're doing synchronized cardioversion, you have to turn it on the monitor. And you'll see these little lights or little triangles at the top of every QRS. Guys, you cannot do synchronized cardioversion by yourself, because if you put that shock at the wrong place, i.e. at the T-wave, when everything's trying to get back to what's going to happen, you just put them in the V-fib or V-tac. You gave them a strong enough impulse at the worst time ever. The monitor knows how to do that appropriately. And so it's got this fat. Now, do we just, you walk in, their heart rate's 120. We're going to shock them. No. Which ones do we shock? Unstable, chest pain. What else? Hypotension. What else? Altered mental state. What is building here? Their blood pressure's low. They got an altered level of consciousness. What's wrong? Oxygen don't go where the blood don't flow. And I know that y'all think that's silly. Guys, that's a premise for everything. Do you think you're going to get an IV on that patient? Their blood pressure is 40 over dead. You're not going to get an IV. You're going to go in there and their veins are like this, flat. There's nothing in there. The blood ain't pumping. Now, what can you do immediately? Pace them or synchronize cardiovert them. This is the most underutilized skill that I have seen used in the ER. Do you know why? What'd you say? They don't know how to do it. Guys, we expect you to know how to do this coming out the door. What if you're unsure? What do? The first day you on the job. You're my preceptor. Hey, would you come show me the monitor real quick? If you don't ask, when is it Murphy's Law gonna kick in? The first day, what's gonna happen? You're gonna have a heart rate of 230. He's like, I'm going down the light tunnel. I'm going down the light tunnel. I was in the back of the ambulance. His heart rate was 210. He was a cancer patient. He really told me that, oh my God, there's a light in the tunnel. I said, don't you go down that tunnel. You stay with me, damn it. He looked at me. I was like, you stay here with me. We did have to shock him. If you can, before I start this, what do I need to give them? Sedation. I'm going to... I had, and it's always a farmer. Man, that feel like a mule kicked me in the chest. Have you been kicked in the chest? It hurts. Don't not do it because it hurts. A tourniquet hurts. Every patient I put it on screamed and cried, please take it off. You're going to bleed to death. I'll unloosen it until you pass out, and then I'll turn back. Blood pressure's 40 over 20. Heart rate's 200. Altered level of consciousness. Diaphoretic, shorter breath, respiration 60. Aggressive problem calls for what? Aggressive measures or treatment. Guys, you can't get a whole lot more aggressive than electricity if they are kind of a weight. Right? These are the rhythms that we synchronize cardiovert. Atrial fib, atrial flutter, supra, what does that mean? Above. Where's it being paced from? Above the ventricles. It might not be the SA node. We're going to talk about that. And sinus tac. Now, and VTAC with a pulse, because usually that rate's going to be what? Somewhere between 200 and 300. That's fast. What do we pace? Slow rhythms. Just any of them? No, they have to have what? An aggressive problem. Hypotensive, shortness of breath, diaphoretic, altered LLC. Their cardiac output, what? Sucks. Why? I'm just not getting...
Their heart's not pumping.
Right! My pump ain't pumping. Well, why does my cardiac output suck here? It's girl, you got the ADHD, it's running up and down the stairs, running up and down the stairs. It doesn't have time. If you're beating that fast, how much blood are you ejecting? You're not. Cardiac output sucks. It does here too. And right here, you ain't got none. So it really sucks. if you do not defibrillate, ventricular fibrillation and pulseless VTAC, I don't care what you do. The only thing that could change that is the good Lord coming down and saying, it's a miracle, stand up. You have got to shock that heart in those two rhythms. I cannot overemphasize that enough. You can do the Gold Star CPR, you're on CPR magazine. I don't care. You can give all the meds, you can give all the fluid boluses, you can get the 14 gauge in their forehead. I don't care. If you don't defibrillate that rhythm, it's not going to stop. For those two, these are the lethal rhythms. V-fib, pulseless VTAC, PEA, and asystole. Everybody knows what this is. Flatline. Y'all know what this is? What is it? Without what? Without mechanical what? Contraction. The lights is on, but ain't nobody home. What can it look like? Anything. Like we had this lady, y'all, it was the most beautiful normal sinus rhythm. It was in every medical textbook ever written, and we're all like, none of us could believe, because we start CPR and it's like, oh, that's beautiful. Like they went and got the Doppler. She was in PEA. I don't care what it looks like. If it's not this sight word or this sight word or that one, anything else that doesn't have a pulse, I don't even want you to think is what? PEA. Don't go any further. You got to do CPR. You got to give epi. That's it. Is that fair? A lot of times, PEA is this wide, bizarre, really slow, this to go into what? Asystole. Does anybody know what the number one cause of PEA is? Blood loss. You always try to think about what happened to cause these rhythms, especially with which two. Yes and yes. How many things can we do for PEA and asystole? Not a lot. If that's my family member, I want to give them that ice crystal on the snowflake chance in hell that they might have. This is where we start what? Does anybody have any ideas? Check their blood sugar. Somebody get an ice test. Oh God, their potassium's 12. Can you treat that? Yes, you can. Oh God, they have a tension pneumo, their trachea is moving over. Put a hole in their chest. It might not work. You can't get no more dead than dead, right? It's only uphill from here. These are the things you need to be thinking at. Why? What am I trying to get you to do? To think critically. You guys are already doing it. You have been developing this for semester upon semester, and you don't even know you're doing it. Everybody in here answered that question. This is where you think through everything and narrow it down. Oh God, their potassium's whatever. Oh God, their sugar's 720,000. Right? That's high. So for sinus tach, the pulse has to be greater than what? 100. What does it look like? And you're going to see this on just about every one of them. Fatigue, dizzy, lightheaded, short of breath. They might have had a syncopal episode. Chest pain. Skin. There's three things I want to know about their skin. What? Temp, color, and what? Condition. Dry, crusty, diaphoretic, glistening, whatever. What assessments would we do? I'm not adding those in because they're all for, what do I need to assess on this patient? Just the generalized cardiac stuff, right? Monitor, SpO2. We're going to get a what? An EKG. Now, there's something in my vital signs, I'm not talking about blood pressure, and we always forget this, that I want to know. What can cause this? Huh? A fever. Guys, a heart rate of I know I mentioned supraventricular tachycardia, right? Does anybody know what rate that usually starts at? Over 150. Now this is not a hard, fast thing. I want everybody to stop and look at me. What can, in an adult, 120 and a baby, like, ah! Okay, it's 120. In an adult, what can cause that? Fever, what else? Pain. Guys, the first place you will see pain, even if they are on the damn ventilator and everything else. If you walk in there and your patients, and they're unresponsive, blood pressure is 200 over 150, their heart rate's 130, they are hurting. Guys, anybody in here ever had surgery and been intubated? That sucks. You hoarse for like 2 days. It hurts. Can you imagine having that tube down your throat and it making you breathe? Or heaven forbid, you're multi-system trauma. Everything in you is broke. Pain. That's the first place you will see it. It can cause a rapid heart rate. A lot of times, sinus tach is not the heart. It's just not. I can still see P wave. When this gets to 200, the only way you can recognize that that's not a ventricular rhythm is what? That QRS is narrow. Because a lot of times, if it gets up to 180, 200, it is so damn fast, you can't tell nothing else but that QRS is narrow. If the QRS was wide, what kind of tachycardia is it? Ventricular. What test are we going to throw in on this? We already said UDS. What is this? Yes, ma'am.
Hyperthyroidism.
Hyperthyroidism. What is your thyroid control? Metabolism. Either I'm a squirrel, a rat on acid, or amphetamine and coke and crystal meth all rolled together, and woo! My heart rate's 350,000. Yay! They ain't hypothyroid, right? Because then they do like, my heart rate's slow. Thyroid count on every patient that's tachycardic. And I don't care if it's got serious signs and symptoms, because I want to know this before. So it helps you figure out if something's wrong with their heart. If their thyroid low, T3, T4 is through the roof, what's causing that rapid heart rate? That. It's not their heart. Cardiac output, a lot of times in this, is not really effective. What meds do we treat it with? Probably not. Which one do we use this on? SVT, which does affect what? Cardiac output. And usually it's a very high heart rate. Beta blockers. Where are your beta receptors? In the heart and the lungs. You have one heart. How many lungs? Beta 1 is in the heart. Beta 2 is in the lungs. If I'm stimulating beta 1, what's it going to do? Well, Ms. Horton, I don't need it no faster. No, I want to do what? I want to block it. Beta 1 blocker. Calcium channel blocker. SVT is usually between 160 and 250 beats per minute. A lot of times, what is the problem? The heart. This is a heart problem. The other one, you need to look for a reason. Do they have anybody in here ever had a temp of 105? I thought I was dying. And I'm sure my heart rate was through the roof. And when I dislocated my hip at home, when I got to Tanoa, I'd had hip surgery. When I got to Tanoa, I got some ketamine too. That was good. My opening blood pressure was 200 over 110, and my heart rate was 125. Why? I was hurting. Was that my heart? It was not. Fatigue, dizzy, lightheaded, short of breath, syncope, chest pain. Maybe not, they might not be complaining of chest pain. What? Fluttering. It feels like my heart's running away from me. Guys, when your heart rate gets above about 160, it hurts. I mean, you will physically, and it's your heart trying to tell you what? Hey, I'm sick. Cardiac output starts getting truly affected. Serious signs and symptoms, what do you need to do? Aggressive interventions, which is what? Synchronized cardio mode. Guys, we don't do that unless it's bad. Is there anything wrong with going ahead and putting the pads on if they look kind of bad? No. Adenosine. Somebody had asked me why it's got such a short half-life. Does anybody know what's in our body? Adenosine. It does not last, I'd have to look it up, but it's a matter of seconds. That's why you have to push this a very specific way. I don't expect you to remember that. It needs to be in the left AC. If you can get a 10 gauge over here, you get a 10 gauge. You need 2 nurses. This is the perfect way to do it, the best way. I've done it in the emergency room. And you have a 3-way stockpile. This one is not flush, this one has got the medicine. And so we talked about this, we're gonna time it. We're gonna say 1, 2, 3, and you're gonna push yours, I'm gonna push mine, we're gonna have the arm up. And it's hooked to a bag of fluids, and somebody over there is standing on the bag of fluids to get it to flush in. If you don't get it in fast, it's gone before you get to the heart, and it won't have any effect. Beta blockers, calcium channel blockers. Here again, thyroid panel, urine drug screen, cardiac output is going to go down. Why is it sinus Brady? Everything else is normal. It's got a P wave, it's got a PR interval, QRS is narrow. It's just too what? It's just too slow. So I can't say it's a normal sinus rhythm, but it's coming from the SA node. Something is just wrong. It's too slow. Now, what's treatment? We're going to run in, we'll give atropine, right? Yes. Is anybody in here a long distance runner? I could bet that your heart rate is in the 50s. Normally. Don't treat that number. What I treat? My patient. You give her atropine, she's going to think she's dying because her heart rate's going to be 130. I know y'all heard me say that. Put the pacing pads on them. If you need, pace them. So, if they are symptomatic, and this is ACLS protocols, if they're not symptomatic, you do not give atropine, and you sure as hell ain't gonna shock them. If they are symptomatic, we can give them atropine, we can give them dopamine, and we can give them epi. Does anybody know what receptor sites this hits? If we're talking beta and alpha. Beta 1, alpha, beta 1, beta 2, what does it do to the lung? We give it to every asthmatic patient that comes in. Bronchodilation. It mimics the sympathetic nervous system. I'm running from the bear. I'm fat and old. I want my heart rate to what? Speed up so I can run faster. And I want to what? I want to open up that bronchos to breathe faster. And don't be like all the people that, Why? Why do you look back and just run and just run? What's that commercial where they go into the shed where they got all the saws and the killers? Yeah, something like that.
Why don't we just get into the running car?
Any medication that stimulates those receptor sites mimics what nervous system? What if I told you it blocks that? So I've got sympathetic, parasympathetic, right? If I get this one out of the picture, which one takes over? The parasympathetic, right? What is atropine? Right. Anti-cholinergic. Now, and guys, I know y'all might be wondering why I keep telling you this about pharmacology. If you can understand this stuff, you can keep yourself out of trouble. Guy comes in, heart rate's too fast. We're going to give him beta blocker, right? Kind of got signs and symptoms. So you give him a non-selective beta blocker, and then he starts having trouble breathing. Oh, I forgot to tell you, I got asthma real bad. I've been intubated 6,000 times. You just blocked both receptor sites. What is going? I can give him albuterol all day long, which is a beta 2. It ain't gonna do one damn bit of good. You have got to know the classes of these more common drugs. I don't even, you're going to give a beta 1, right? Metoprolol. I want to bring it down. Beta blocker. What do I need to monitor before? Heart rate and blood pressure. What do I need to monitor after? Heart rate and blood, there you go. Because it's a beta blocker, right? Epinephrine does heart rate, beta 1, beta 2, and one. Guys, it's not that I don't care about alpha 2, but it's not so important in our world. What is alpha 1? It's the squeeze. That's all I want you to know. It's vasoconstriction. What kind of medication is this? When their blood pressure is 40 over dead. It's a vasopressor. It changes the size of the container. If this is the pressure that's in here with this volume, and now this is the same volume compressed down to this. What's the pressure now? It's through the roof. I didn't do anything but change the size of the compressor, right? Alpha 1 causes smooth muscle vasoconstriction in your periphery. Now, might you get too much constriction? And that's why you see some of these patients that are on these strong vasoconstrictors start having the what? Fingers tied. Yes, ma'am.
Are there EKG changes of thoughts, or is it just sinus and like dropping between tasking right here?
With what?
Pops and dropping? Is there EKG changes with it, or is it just fluctuating sinus?
I don't know the answer to that. I'd have to look it up. Cardiac output is going to what? It's going to be bad. If it's truly bradycardic and affecting their perfusion status. So, guys, this is the number one rhythm that we get as we age. It just is a thing. What's the problem here? What are the atria doing? They're not doing what they need to. And y'all, when I give you these examples, I promise that it really does have something. Anybody ever been out in the country and you see that pond that's stagnant? It's got what going on? It's got like a moss, that's algae that's like that thick. Anything that sits long, lays stagnant long enough, grows what? Moss. What's in that heart when it's quivering? Clots. That's why if we can, I don't want to shock them. If this is new. Now, if they've already been on like what? Blood thinners, warfarin, Eliquis, any of the new ones, they're a lot more prone to shock them in the emergency room. I'm not saying I'm not going to. Aggressive problems, aggressive interventions, but what do you run the risk of doing? And when it happens, it's like microclots, and it's a watershed event. And that's bad. You can't not do it. What do you think they're going to give them pretty immediately if I have to do that? We're going to start giving them heparin in case there is something that's dislodged. That is the number one risk with atrial fibrillation, even if you aren't having signs and symptoms from it. Yes, ma'am?
So is this something that you like encountered in working in the hospital, or is this like something they tell you in the hospital too, like don't shock? Or, you know what I'm talking about?
So I just gave you the pathophysiology, right?
Yep.
And this is what I'm trying to get you to think through. It's quivering. The blood is stagnant a little bit. It's making clots. Do I want to punch the heart? What's it going to do? It's going to release those clots. Same thing if you had a DVT down here. Do I want to massage your leg? No, better not. They're going to get immediate anticoagulation therapy. problem in the atria, right? When the blood dumps in, what is that called? It's a hemodynamic term. It is the amount of blood that is preemptively coming in. Preload. This is it. I ain't got no other amount of blood that's going to come in. Whatever amount is here is the amount of blood that is preloaded to go out where? To the body. If I got half the volume coming in, my preload is what? Half. And my cardiac output is what? Half. If you're bleeding out, what is your preload? It sucks. I don't have any blood to beat out. If I've been throwing up for 7 days, what is your preload? It sucks. I don't need a central venous monitor to figure that out. If you just think through it, right? So, there's a problem with the atrium, and I know you probably have heard this term. What if their ventricular rate is 200? Is that bad? I got a bad problem with the atrium. Now what? I got a really bad problem with the ventricles. It's atrial fib with rapid ventricular rate. Oh, that patient in room 7's got atrial fib with RVR. Have you ever heard that? And then you're like, what's RVR? I don't know, but I ain't asking because ain't anybody else asking. There's already a problem with the atrium. Preload is affected. I've got clots. Now my ventricle's acting out. And I'm not ejecting any blood that I had half of to start out with. Half minus half is none. Atrial fib with RVR, they usually are really, really sick. And usually when they come in, they've had atrial fib in the past. Thank God they're anticoagulated a lot of times when they come in. And you'll see them give them medication to slow this down. Your heart cannot stay like that because your cardiac output is awful. Beta blockers, calcium channel blockers. What is this medicine? Digoxin. It does kind of slows the heart rate down and kind of makes it beat better. NCLEX loves this question. I'll have to look at the test, but I think I do too. What is the number one sign of DH toxicity? Very specifically what? The patient will tell you, man, do you see that light up there? It has a yellow, they're on every angel. Halo. That is a hallmark sign. Nausea, vomiting. And they might not describe it as a yellow halo, but they will tell you that something is around all the lights. That is, I don't know, there's certain things that NCLEX loves, and that's one of them. It might behoove you to understand that. Even if they're not on anticoagulants. What if I never knew that I had this congenital part and you get my CBC and my platelets are like 600,000? What might be causing the problem? I might have a clot in there anyway. What is this? Is it 100% specific?
No.
It's not. It's something that we use to kind of rule things out. Chest pain, shortness of breath, a dry cough. It is a deadly triad for what? PE. They're going to draw a D-dimer. If it is, I had one that was positive for COVID. It was pretty positive. And the PA walked back in. My heart rate was pretty high. And he said, Shayla, I've got to do it. I've got to do a CTA on you. It's looking specifically for blood. I didn't have one. So it just meant that there was injury and that irritation in there. It is not specific. Is there, oh my God, she got no. And it's not specifically for your lungs. It's looking for a possible clot somewhere. Beta blockers, DH, calcium channel blockers. A lot of times atrial fib just by itself, especially if they've had it and they're not in RVR, don't cause serious signs and symptoms. But when somebody has atrial fib, gets real sick, what's going to happen? They've already got a bad heart. They're going to flip into atrial fib with RVR. We saw it a lot during COVID. Guys, I know we've been sitting here a long time. I don't know how else to get through this. Atrial flutter. Now, what's rate? 11. So, then we go to rhythm. Guys, it is regular. This is. This ain't. That's P waves. Does it have P waves? It does. Do they all look alike? They do. There's way too many of them. So there's a problem where? In the atrium. But we're not going to call it sinus tach because there's something wrong with the P waves. This is that hallmark sign. There's a reason it's not atrial tachycardia. It has flutter waves. That's what these are. And it's regular. Because sometimes you're like, is it atrial fib? Atrial fib is irregular. A lot of times, about 90% of the time, atrial flutter is not. Atrial flutter is regular. Atrial fib is not. With any of these rates that are too fast, what is our goal? Slow it down, prevent clots, and improve cardiac output. Same drugs, same test. If the rate's 200, hypotensive, chest pain, whatever, what are we going to do? It's a fast rhythm, synchronized cardioverter. What does VFib look like? Pulseless, apneic, dead. That's it. VFib does not have a pulse. If it does, it's not VFib. You follow ACLS protocol. What drugs do we give? What's first? Epi. Guys, I don't want you to memorize the dosage. If you know the dosage, that's great. And you can even tell me during the mega code. Now, here's the thing. Guys, I'm very humble. When the paramedics check off for NCLEX, you have a hands-on mega code. Guess which one I always did? Cardiac. If you don't pass the hands-on, you don't pass for the did I say it? It's National Registry. If you don't pass the hands-on part, you don't pass National Registry. You just failed. You'll have to come back and do it. I don't know if they thought they needed to impress me. I was like, it's either lidocaine or amiodarone. It's your choice. Guys, lidocaine is 1 milligram per kilogram. There we go. Let's go. Ready, say, go. Put me in, coach. If you gonna throw amiodarone out there and you're supposed to give me the dosage, I'm going to what? Ask the dosage. Guys, if I'm not asking you for the dosage, don't even put any brain power towards that. If you want to look it up, that's fine. All I am testing you on, now you've got to know the drugs. Epinephrine. What class drug is this considered? It's an anti-arrhythmic. They in a rhythm I don't want them to be in. Anti-arrhythmic. It's either amiodarone or lidocaine. Guess what all the studies have said? There ain't no difference. Ain't one damn bit of difference. Is it, if we get them back, we all in there go, we did it. Does that matter in the emergency room? It don't. What do I want to know? Did they walk out of my hospital pretty much intact? It's great if you save them, and it makes you feel good, and you should, because you did everything we taught you to do. That's not the bottom line. I can save them in here, and they go up to the ICU and die. Did we really save them? You didn't. We did our job, yes, and that's the part that sucks sometimes, is we all high-fiving, and we're proud of ourselves, and you should be. But you can't say that doesn't affect you when your friends up in the ICU said, hey, that patient was room 7 died. But what about if they tell you, hey, that patient walked out yesterday? Now we all high-five. We were running down the hall high-five. Immediate defibrillation. Nobody asked, do you need me to get it? Yes, yes, and yes. Get on CPR. Starting with compressions. Pulses VTAC. Immediate defibrillation. If they have a pulse, they're going to tell you, if it's rapid, that they're having what? Palpitations, dizzy, all the rest of it, maybe even chest pain. Once they lose that pulse, it's just like VFib. DFib, the same medications. Epinephrine, amiodarone, or lidocaine. Now there are others as we go down. I'm not holding you responsible for that. Guys, you can look at it if you want to. But if you like me, I only got so much space up here. I don't, it's not useless, it's needless. Does that make sense? I want you to know what class drugs these are, because you're going to see them a lot in an epi drill. Using a vasopressor. Who's in the ICU? Oh, honey, you're going to see it, especially if you at Skyline, Vandy. I mean, we see it at Tenova too. It's very frequently used. Hold on. Do all of these look the same? They do. What does morphology mean? If I said it's monomorphic, how many pacemakers is it coming from? One. How about polymorphic? A lot. Me and Dr. Wilt went back and forth when we first started teaching this about whether we were going to introduce torsades. Until we found out it's in the 9 rhythms that y'all were tested on, and Influx likes it. I probably have seen it maybe 6 times in 26 years. It is a unit. And then I say that, and 3 of the 6 happened at Tenova in 2 weeks. And girl, I got copies of the monitor techs down there have got used to me barging in and said, oh my God, did you get the first of that? And so they're like, here, stop. You just don't see it. Polymorphic ventricular tachycardia, torsades, D. That's French for a twisting of the points. If you took regular VTAC and did this with it, what's it going to look like? Guys, this is not VFib. That doesn't look the same. If this comes in early enough, will they have a pulse? Yes. Are they going to keep that pulse if they are in this? No. This is not a perfusing rhythm. Who gets this? Alcoholics. Who else?
People on QT prolonging medication.
Renal failure, they just left dialysis. What's out of whack? Their electrolytes. Renal failure. Alcohol. Why are alcoholics? They rather what than what? Drink than eat. There was one more, and I had never seen it on this. It was always, the first one was renal failure. The next one was a bad alcoholic. I don't think he had nothing to eat in 6 years. It was one of the hottest summers here, if you can believe that. It was like 100 degrees, and guess what they had downtown? The marathon. She was running it and fell out and started seizing. We thought her sodium was off. This happened before. They rolled through the door altered level of consciousness, and I don't even remember what, is that Vandy in ER? I don't remember what was on the monitor. She flipped into torsades. Do you know what the doc started hollering for? Magnesium, guys, it stops it like that. 2 grams over 2 minutes. What is magnesium? What class is it? When do we give it besides this? Where's my L&D nurses? What do we give mag for? Pre-clamp, not even that. Pregnancy-induced hypertension. How does it work? Why do I give it to an asthmatic as second-line treatment? What's in here? What's your lungs? Smooth muscle. What's your uterus? Smooth muscle. What is going to calm down your heart? Your muscles. If they lose their pulse. Guys, this is polymorphic ventricular tachycardia. It's still VTach. If they lose that pulse, you treat it just like monomorphic. Immediately defibrillated. You're still going to give them what? Magnesium. And guys, I have seen, this is not, if we're running the code, you can actually suggest it. I've seen physicians give monomorphic VTach, but we can't get them out of it. I've seen them give them mag. Just, well, we don't hurt. Guys, this is asystole. There's 2 things I want to check when I go in. Even that. When I walk in, what am I going to do as I'm walking in? Hey, Mr. Jones, what? And his leaves are on the floor. Guys, I'm dead serious. He might be sleeping good, and you finna go over and start CPR. We got a 911 call, no crowd. The patient won't sit still and let them do compressions.
Well, then they don't need compression.
Guys, we got there in his chest. Thank God they were holding him down to do compressions. Now, there was a lot of Jack, Jim, and Jose that was involved in that, but I tried real hard not to laugh. I failed. Make sure it's asystole. If they ain't got no pulse, and that's what you see, it's asystole, and they're on the monitor. Immediate CPR. Do we defibrillate this? No. What bed? Epi. That's it. What do we need to start thinking about? How did we get here? Was I in a car wreck, multi-system trauma, maybe what? Blood loss. Let's give them some blood. They've taken this, I don't know why, they've taken this out of the, you'll hear it called the H's and T's. That's the reasons to get you thinking. Hypovolemia, they're bleeding out. Hypothermia. What does hypothermia do to the heart? It does, and it makes it very irritable. Somebody's not dead until they're what? Warm and dead. They have to be brought back to room temperature. So then you're going to say, well, Ms. Horton, why when somebody has a heart attack, do they put the Arctic sun on them? Why are they doing that? I want to slow it down and try to let it rest, and then they'll bring it back up to room temperature. I think this is last one. PEA, anything it can be. It has to have electrical complexes, and it cannot be 1, 2, or 3. That's it. If it's not VFib, it's not pulseless VTach, and it's not asystole, there's electrical contractions, complexes on there, but no mechanical contraction of the heart is PEA. That's it. You don't even have to put any thought in that. If it ain't them 3, it's PEA. I know this was fast. Did it at least help? Guys, don't be scared about this code tomorrow. This is used as a learning opportunity. How many people have been involved in a code right now? As in giving CPR or something. How many people have at least seen one? How chaotic is it? I mean, there's several different monkeys and circuses at best, and there's several different wrangling octopuses at work. Versatility Day. It's employment.
You're